Hello everyone. I am back with a new video, and this time is heart failure. A lot of students tend to be sort of scared of this topic. It's a huge topic for our test, and so I want to take the opportunity and the time to really go over the overview and kind of break it down a little bit slower for you. So let's get started. So, heart failure is when your ventricles or the pumping force of your heart um, basically gets damaged and your heart becomes sick, the muscle becomes weak, and then therefore the heart cannot pump the sufficient amount of blood to meet the demand of oxygen around the tissues and organs. Now, depending on which side fails, like whether it's the left or the right, or if it's just congestive heart failure, it's what your symptoms will look like. But in overall, it's basically a inability of the heart to pump sufficient blood. Now, the book talks about 6.5 millions of people suffer from this. This is a big cost for hospitalization in the United States above the age of 65. And it costs billions of dollars to take care of these people, as well as they usually have other comorbidities as well. So let's review a little bit of what happens. So as the blood is decreased, when it comes out of the heart, like this, the blood pumping out of the heart is less. Everything starts pulling peripherally because it doesn't have that same force and that same amount. So it kind of gets staggered in the areas peripheral or peripherally from the heart, like the legs. So then you have all these symptoms that happen. You can get edema of the ankles and legs. And then as it comes back up, it starts like backing up into the heart. And so, especially if that right side of the heart fails, so then things start backing up. And I'm going to explain this a little bit in a few more slides. And then you can get into lung problems where blood starts pulling up in the lungs, and so that causes lung congestion, which is like water, so to speak, where then you will have all respiratory symptoms such as shortness of breath, tachycardia, tachypnea. You can have crackles, decrease oxygenation levels, etc. But I'm going to make a picture a little bit better in just a few slides. What causes heart failure? Well, there are things outside of the heart sort of that can cause it, and there's factors inside the heart. So some of the factors outside could be coronary artery disease, like those vessels around the heart outside that provide oxygen to the muscle, hypertension, pulmonary hypertension, diabetes, sleep apnea, obesity, smoking, drugs, alcohol, etc. Factors in the heart could be atrial fibrillation or flutter. So dysrhythmias can cause this, as well as heart attacks. And any valve issue as well, any problems with the valves of the heart. There's different diagnostics that we can do to not necessarily diagnose it, but also to see the degree of how bad it is or what potential could be the cause of it or what led to it. So with big stars, I want you to remember that B-type natriuretic peptide or BMP, it's the sort of the hallmark lab diagnostic quick that we can use to diagnose heart failure. The reason for this is because this peptide is released whenever the ventricles stretch, and because they're overloaded with fluid from fluid being or blood being backed up, then you have this peptide being released. So normal levels is below 100. However, when someone is being diagnosed with heart failure or is an exacerbation in heart failure, you're going to see these numbers in thousands, hundreds. The other day, I was seeing a patient's chart, and the lab was like 11,000 something. So we're talking big numbers here. So, something along the 100 or 150 doesn't scare a physician when they're trying to diagnose heart failure. Another thing that we can do is an echocardiogram, and we can look at the ejection fraction, that EF that I have listed here. So an echogram is a ultrasound of the heart. We're looking at the valves, how they're closing. We're looking at the flow of blood coming in and out of the ventricles and atriums. And so the ejection fraction is how much blood is being pumped out of the heart. And whenever the muscle gets weak and sick, the ejection fraction decreases. So the less the ejection fraction is, the sicker the heart is. Another thing we can do is just simple chest x-ray just to see at the size of the heart. If you notice on this picture I have here, the heart is enlarged because as the muscle works harder and harder to pump because it's weak, the muscle grows and it gets bigger and bigger and bigger. Other exams that we can do are CBC, liver function, electrolytes, EKGs, or urinalysis. But this is just really to find out what kind of led to heart failure. Was it maybe diabetes? Was it a dysrhythmia? Was it maybe coronary artery disease and the vessels were blocked, our arteries were blocked? And so the other diagnostic tests are not necessarily to diagnose it, but more to see what factors led to it. Okay, so here's the main thing that I want you to understand when it comes to heart failure, kind of how kind of how the blood flows and how it starts happening. So you have to remember back to pathophysiology where blood comes from. So it comes from the inferior vena cava up to your right atrium, right ventricle, pulmonary veins, or arteries, not veins, and then left atrium, left ventricle, and then up to the body. So I always relate this to a traffic accident. So whenever a traffic accident happens, initially you might have one or two cars backed up. But as the traffic starts slowing down and the inability of the cars moving at the same speed, you're going to have cars backed up for miles and miles. Or if they close the road, miles of vehicles being backed up. Well, that's why I kind of put this picture here because it sort of happens this way. So if my right atrium, or in this case, my right ventricle fails, if it's a right-sided heart failure, you're gonna start having symptoms in the lower part of the body or the rest of the body because blood starts pulling back where it comes from, and it came from the inferior vena cava, meaning the rest of the body peripherally. So now, if it backs up or if it fails on the left, then you're going to have the backup or the traffic jam to the left atrium, to then the pulmonary side, because again, it comes from the pulmonary artery, basically. So that's why left-sided heart failure has lung symptoms, okay? So when you're trying to figure out the symptoms, you need to understand where is it coming from? Where is the blood coming from? And think about a traffic jam. That's my tip to you. All right, so let's look at the symptoms. So right-sided heart failure, rest of the body. So you have fatigue, you'll have the edema, you'll have ascites, like just that fluid in the belly. You'll have distended jugular veins. You'll get gain weight. So a lot of fluid being built up around the body. When you're looking at left-sided, because it comes from the lungs being oxygenated, then you think about lung problems. It's going to start pulling in the lungs. So you'll have like fluid basically in the lungs, which restlessness, confusion, tachycardia, dyspnea, orthopnea. You can have frosty sputum, almost sometimes blood tinge because of capillary filtration. They have to be sleeping almost like in a sitting position or elevated because they can breathe better, and they'll have wheezes as well. In general, these clients look like with many of these symptoms that I just mentioned. They'll urinate at night a lot because of all that extra fluid. They want to pee it out. They could have the abdominal distension. They'll have skin that is dark, shiny, and the hair is lost. Elevated heart rate, fatigue, all of these I mentioned already. So in general, these are the symptoms. But however, if you're trying to see if it's left or right, then right for rest of the body, left for lung problems. Some of the complications that can arise from heart failure are thrombus or clots in the ventricle, left ventricle. Because again, the blood is pooling there because the heart, it doesn't have that strong squeeze or contraction because it's weak, it's sick. And so they can develop the clots from just pooling, the blood pooling there. You can have dysrhythmias, pleural effusion, and also renal insufficiency. Well, now that we diagnose, hey, someone has heart failure, well, then what? What do we do for these clients? Well, let me tell you, someone can live outside of the hospital with heart failure. They don't have to be hospitalized every day. However, something can happen, whether it's in compliance with their meds or their lifestyle, or their diet that can lead them to a heart failure exacerbation. And so that is why it's very important for us to teach our clients what they need to do to prevent hospitalization. So first and foremost, we need to look at the nutritional therapy where we recommend them to do a low sodium diet. Why sodium? Well, sodium attracts water. These people already are overloaded, with fluid that is being backed up. So we want to not increase fluid. We want to basically decrease the fluid, and sodium attracts water. So a cardiac diet is also suggested because, again, most of them have cardiac problems, coronary artery disease, and so you want to make sure that their diet is sort of a clean eating. More on this is on page 747. You have your low sodium diet nutritional therapy for heart failure clients. The fluid restriction or monitoring the fluid, you want to make sure it's less than 2 liters a day. These are the clients that we don't want to overhydrate them. We want it to kind of, they have a little fluid, so they don't become dehydrated, but still, not that much. Also, because they could have pulmonary issues where the lungs are filled with fluid, you want to supplement any oxygen. You want to assess their lungs constantly to see if they're getting worse or better with that fluid in the lungs. You want to elevate the head of the bed, or when they're sleeping, kind of prop them in pillows so that way they're not flat. They don't really typically like flat. They can't breathe, so they want to be a little elevated. You want to monitor their vital signs to see if any changes but also their weight. Their weight is going to be very critical for these patients because their weight is going to tell them if they are retaining extra fluid. So the rule is they have to report a weight gain above 3 pounds of 3 pounds in 2 days, or 3 to 5 pounds in a week. If that happens, that means they need to tell their physician and something is not working and they could decline very quickly. Monitor their intake and output. So whatever goes in needs to go out. Assess for edema, assess for oxygen saturation, monitor that BNP to see if it's getting better or worse. Help with LDLs. Well, we help them perform their LDLs like showering, getting dressed because they're short of breath. Also, another thing is eating. Since they are short of breath most of the times and tired, we want to promote some rest in between activities. Same thing that we uh, help the patients with COPD. We want to see if what the patient has as an ejection fraction, because usually you may consider implantable cardioverter defibrillator if the patient has a ejection fraction of less than 35, because that means your heart is barely pumping. And so you could go into a ventricular dysrhythmia. And then heart transplant is the last resort. But, heart transplant is not something that you can just go to the store and buy. And so it's very difficult sometimes to get one. Now, we do have a pharmacological therapy that we can use for these patients. And guess what? It's surrounding fluid, okay? So when you think about heart failure patient, think about the contraction. We're going to give them medications that help with contraction, and we're also going to help with fluid. So diuretics, and let me tell you, these four at the top, we've already discussed in my hypertension video. So if you're looking for the explanation on these meds, are going to be on medication, antihypertensive medication video. So diuretics, again, taking the fluid out. ACE inhibitors, not retaining fluid. It deals with the sodium and water retention in the body. Same with angiotensin, 2 receptor blockers. And the beta blockers, what they do is they slow the heart rate down. Again, if the pump is not functioning, but we can slow it down, maybe it allows the heart enough time to refill and pump effectively. So that's why beta blockers are used, because it lowers a little bit of that heart rate, creating the pump a little bit more efficiently, or that cardiac output efficiently. But the drugs that we're going to talk here in this lecture are positive inotropes, digoxin, and anticoagulants. And so another classification of medications that these patients get are anticoagulants, because I told you one of the complications is clots, because the blood is pooling. So they might have to be in an anticoagulant if their ejection fraction is less than 20, or they have dysrhythmia such as a flutter or a fib. Okay, so let's talk about positive inotrope drugs. So basically these drugs, digoxin, or digitalis drugs, they work they have two functions. They basically increase the force of the contraction, which we want for these patients because the contraction is weak, but they also work in the electricity a little bit. So that's why some of these drugs, you're going to see them in the dysrhythmia video, okay? And the dysrhythmia video, I talk about digoxin as well. So digoxin increases the contractility of the heart, but it also changes the electrical conduction and properties of the heart. in the end, it results in a reduction of heart rate and improves the cardiac efficiency. The problem with digoxin is that digoxin can be a little troublemaker drug. I call them a troublemaker medicines whenever they interact with a lot of things, or they have toxicity issues, or they cause trouble for patients. So, and this is one of my um, drugs that it's troublemaker. So the therapeutic window of digoxin is very, very narrow, very small, 0.5 to 2 nanograms, okay? And you need to memorize that for the rest of your career. That is the therapeutic level. Electrolytes should be monitored constantly because low potassium can increase the toxicity of digoxin, and also the kidney function needs to be monitored. So some of the things that can predispose someone to have toxicity of digoxin are low potassium, dysrhythmias, high calcium, kidney, respiratory, and thyroid disease. And also your age. If you're older, you're more at risk for digoxin toxicity. Well, what does digoxin toxicity look like? And this is very important to teach not only patients, but their family, because watch the symptoms here, watch the side effects here, and on toxicity. It's confusion, one of them in the central nervous system. Well, listen, if someone is confused, they might not recognize, hey, I'm confused. But the family is going to recognize that they're confused. So that's why we involve the family big time. So, anyways, the symptoms include dysrhythmias such as tachycardia or bradycardia, headaches, fatigue, confusion, seizures. And then this particular halo, discolor vision that happens on patients. It could be green, yellow, or purple. And they have kind of like flashing lights and sometimes a halo ring around their vision. They could cause anorexia, nausea, and vomiting, and diarrhea. So some GI symptoms as well. What do we do when we're caring for this patient, or when someone is on digoxin, or when we're going to administer digoxin? That's very important for a nurse to know. Well, first of all, we need to assess the history, drug allergies, and any contraindications, such as like kind of like low potassium, like look at their electrolytes, look at, is this a kidney patient that might not, might be contraindicated. But we also have to check their blood pressure, because it can lower blood pressure, and their apical pulse. It lowers the heart rate. It's kind of makes the heart rate a little slower, but increases the force of it. So we need to make sure that the apical pulse is at least, check it for 1 minute. And if you have a dose that it's typically 60 or less, we hold it. We notify the physician, we hold the dose, and we tell them, hey, how do you want to proceed? Now, some institutions, some hospitals will say less than 55, but rule of thumb is 60. That's with it also a beta blocker. But again, you have to kind of follow policies of your hospital too, or doctor's orders. You want to monitor heart rate and breath sounds. You want to monitor their weight or their in and out to see how good or how worse they're getting. Check their EKG for any dysrhythmias, and monitor all these laboratory electrolytes or lab tests, such as potassium, sodium, magnesium, calcium, kidney, and liver function. You want to also avoid and teach your clients to avoid high fiber foods, because fiber binds to the drug. And so we tell them not to eat high fiber meals or food items, and then report their weight if needed. Okay, well, I hope that was helpful. That's a quick, review of heart failure. Again, my references are the book, and all my images are from Google, and I will see you in the next video. Bye bye.